In this video, we're going to talk about all things cervicogenic headaches. So if you're someone who treats cervicogenic headaches, or if you're someone who has them, you will likely find some benefit from this video. In the video, we're going to talk about causes, anatomy, treatment, diagnosis, and then other things that you can do for cervicogenic headaches. So let's get right into it. What you'll see here is that from an anatomical standpoint and from a causal standpoint, those things are very related. So from an anatomy standpoint, we're going to be looking at the occipital nerves, the C1, C2, because the upper cervical spine is really most important when we're talking about the causes of cervicogenic headaches. We're going to be looking at the muscular system, so the suboccipital muscles, the trapezius, and the SCM. When the anatomy becomes dysfunctional or there's too much tension in the muscles, which pushes too much pressure on the nerves, or there's not enough upper cervical joint mobility, that's where we see the referral of cervicogenic headaches. So the anatomy directly relates to the causes. You'll see that there's almost a continuum of how those causes will then have a very correlatory symptomatic presentation of headaches, neck pain, decreased range of motion, potential referred pain. We're also going to get into the diagnosis and treatment. So things that you should be asking in your physical exam, past medical history questions that you should be asking. And then also, what are we doing from a treatment side? Obviously, from me, I'm going to be focusing on the physical therapy management, but we're going to touch on lifestyle modification, medications, alternative therapies. So let's get into the Essential Anatomy app. And I want to show you some of these anatomical contributions. So with cervicogenic headaches, what we're primarily looking at is the upper cervical spine and then the musculature that relates to the upper cervical spine or that runs from the shoulder girdle to the occiput, all the regional anatomy there. The main ones are the atlanto-occipital joint and the atlanto-axial joint. So the atlas is C1, and you can see C1 here. It has no spinous process. It has large transverse processes. There's room for the dens to poke through with C2, and that's our axis. So we have our atlas and our axis. Right around here, if we add the layer of the nervous system, we can see these nerves that run up to the back of the scalp and almost pull around the head. And for that reason, when someone has cervicogenic headaches, they'll often describe it as a ram's horn type of presentation that draws around their head. This nerve here, the greater occipital nerve, comes from C1, C2. And so you can see if there's a lack of mobility or a lack of movement at C1, C2, or as we layer on the muscles, if there's limitation in those muscles, we're going to have constriction or decreased mobility of that nerve as it passes through those structures. So we have the greater occipital nerve here. Going off to the side, we have our lesser occipital nerve, also comes from C0 to C2 area. It's not as important because you'll see what's most important is understanding the layering of these structures. So the occipital nerves can be causes of cervicogenic headaches, but those are likely a symptom of something else that's going on. So those nerves are getting compressed because of a lack of mobility in the neck, a lack of range of motion, tightness in the muscular system. So we talked about the occipital nerves. We talked about C1, C2. With C1, the atlanto-occipital joint, that is going to be the head nodding motion primarily. Because of how the C1 anatomy matches the occiput, that's really our flexion and extension of the head, that up and down nodding type of motion. With C1, C2, our atlanto-axial joint, that joint has tons of rotational range of motion. So that's your ability to quickly move through your head and neck for positional changes, for assessing the environment, those sort of things. And when that becomes limited, let's say I'm in a forward head posture for a long time, the mobility at C0, C1, and C1, C2 becomes restricted. It becomes restricted as the muscles around there start to tighten and stiffen, and that decreases mobility of the nervous system through there. So we have C1, C2, the occipital nerves, and then here we're adding layers of muscles on, and I'm showing you these suboccipital muscles. So you can see that that occipital nerve runs or traverses through the posterior triangle of the neck. The suboccipital muscles are made up of the rectus capitis posterior minor, rectus capitis posterior major, your obliquus capitis inferior, and then obliquus capitis superior. These are almost self-explanatory, and the names of them tell you which direction they run and where they run to. We have ones that run from the occiput to C1, occiput to C2, C1 to C2. It basically provides support through all different directions of the head there. When those muscles become tight or restricted, they themselves can have a referred pain for cervicogenic headaches, or they can block the nerves that run through there, as I mentioned a second ago. Other muscular contributions to cervicogenic headaches are going to be our SCM muscle, the sternocleidomastoid. That runs from both the clavicle and the sternum, and then it ends up over on the mastoid on the backside of the occiput here, I believe the mastoid process. Again, through a nerve referral type of pattern or a sensory neuroplastic change pattern, then we can see cervicogenic headaches stemming from this muscle. I often think about it more from a postural standpoint. When someone goes into a forward head posture, it changes the angulation and the function of this muscle in the front, as does it change with the suboccipital muscles. Lastly, as we add one more layer on, the upper trapezius, so the part of the trap that runs from C0, from the occiput down to C7 along the nuchal ligament, that can be a contributing factor to having cervicogenic headaches as well, because of, again, how the nerves need to poke through the musculature. And if these muscles are being overworked or positionally stressed, then we'll see their lack of function changes the mobility in the upper cervical spine. Going back over to our mind map here with cervical pain and headaches. So the causes of it are going to be directly related to the anatomy. We can have muscular tension that's causing the headaches, joint dysfunction at C1, C2, injury, posture, and nerve irritation. If someone comes in with a whiplash injury, that can be a quick traumatic injury that can then relate to headaches afterwards. But for me, it's the combination of where does their lifestyle sort of match why they're having those headaches. So if someone comes in and they tell you that they're doing work on a computer for hours at a time, they're not getting very much movement, they don't have much visual changes where they're staring at a screen all day and not changing their depth perception at all. Additionally, that position, looking at a computer, draws C1, C2 into an extended position. So it's a forward head, but extension of the upper cervical spine. That creates tension in the suboccipitals. It creates tension in the upper trap. It creates this working stress across the SCM. Those are all causes then of the cervicogenic headaches. So what will we see? We'll often see a unilateral headache that has sort of a ram's horn distribution. They'll likely come in with neck pain as well. Because of that neck pain, they're going to have decreased range of motion or guarding in their range of motion. And then we'll see referred pain, that pain pattern that either wraps around the head, or you might see some referred pain down into the upper trap, almost mimicking over to the shoulder. You could even see somewhat of like a Cloward's type of area pain, where pain runs down the interscapular line. Oh, from what we need to do then from a diagnostic standpoint when we're assessing their symptoms is a good physical exam. And from a physical exam medical history standpoint, we need to ask what's the presentation of their headache symptoms? When does the headache come on? How long does it last for? Past medical history, have they had any prior injury to the neck? Have they had any recent life changes where maybe they've changed their job or the level of stress in their life has increased, which could contribute to pain as well? Imaging and tests, this will be if things are not getting better with conservative treatment, you can do a CT scan or you can do an imaging just to rule out any anatomical anomalies that are in the upper cervical spine. And then if someone again is not getting better, you can do diagnostic nerve blocks to see if that helps their symptoms. So they go in and do an injection in the upper cervical spine. It blocks the nerves from referring their pain. And that can be diagnostic in the sense that if that takes away their symptoms, then likely the nerve block was showing you that the nerve there is the cause of their symptoms. When we talk about from a diagnostic standpoint with physical therapy or physical exam type stuff, we need to check how the upper cervical spine is moving. So we need to see how well can they flex and extend at the OA joint. We need to see what their upper cervical rotation looks like. For me, I'll take them into full flexion, which locks out the lower cervical, and then I'll assess C1, C2 by rotating from a fully flexed position. That's how I assess C1, C2. From a other physical exam standpoint, palpatory exam along the suboccipital muscles looking for referral or recreation of their headache. Trigger points in the upper trap referring again into cervicogenic headaches. And then the same thing with trigger points in the SCM. It's very common to find tightness or trigger points through here that they'll feel referring up into a headache type of pattern. So I'm looking at joint mobility, tenderness to palpation, and trigger points in the musculature, the anatomical musculature. I'm looking at total range of motion, both active and passively. I'm assessing the strength of the deep neck flexors. So if someone's here throughout the day in a forward head posture, they're likely going to be weak in an upright postural position of the body. You can see as I do that, when I go here, the chest drops. I'm going to have tightness through the pecs with that position. And then also I'm not going to, it's a hard position to hold my head there. It even changes the intonation of my voice somewhat. If we're checking neck position and posture, well, then we need to check scapular muscle strength, upper trap, middle trap, and lower trap strength, as well as the position of the scapula to hold the head over the body. Last thing on that is, if you're assessing all those things, if you're here quite a bit throughout the day, from a side standpoint, you can see my thoracic spine and my CT junctions getting pulled into a flex position. That creates tension or almost a hinging at the CT junction area, so C5 to T1. And then that puts the upper cervical spine in an extended position. So in addition to looking at scapular strength, deep neck flexor strength, we need to make sure that the thoracic spine has enough mobility to allow the head to sit on top of the body. If the person can't do that, we can just assume that the upper cervical spine is taking on more stress and strain, which can lead to then cervicogenic headaches or just neck pain in general. So we talked about the diagnostic criteria that we're looking at with cervicogenic headaches. And then lastly, from a treatment standpoint, we need to triangulate our findings from the physical exam and the medical history to help build a plan of care for this person. So if we see that they have decreased neck range of motion, we need to work on neck range of motion. If it's a joint mobility problem, that might be something that we need to do with hands-on treatment or dry needling, some type of modality where we can get that area moving. And then from a home exercise standpoint, we need to keep those joints moving. So different snag type of techniques where you're using a towel to increase mobility in the neck, that can be beneficial. If they can barely hold a deep neck flexor test where they don't have the ability to use the deep muscles on the front side of the neck, we need to strengthen those muscles. We need to strengthen the scapular muscles because that's going to help hold their body in a good position to support the neck. Now, I gave the case scenario earlier of someone who was on the computer for a long time throughout the day. And that from a lifestyle modification, we probably need to tell that person they need more mobility, just like regular movement and endorphins kind of pumping through their body throughout the day. So getting up and moving every 20 to 30 minutes, just simply changing their neck position every 20 or 30 minutes if they're on the computer for long periods of time. That sort of stuff is the life integration, the psycho-emotional component of pain that also needs to be addressed in addition to the physical therapy treatment. From a medication standpoint, often over-the-counter NSAIDs can be helpful. So ibuprofen, Advil, that can help decrease inflammation that can be contributing to compression on the nerves. Muscle relaxers, which can be prescribed to help decrease muscle tension, and that'll also help improve mobility. Those sort of medication things, we don't really prescribe those as physical therapists, but know that those can be a good adjunct, especially if someone's not responding to the physical corrective positionings you're giving them. From a alternative therapy standpoint, acupuncture and chiropractic has decent evidence behind it on other types of services that can be used to help with cervicogenic headaches. For me, I go back to the underlying cause. If we know the cause is decreased joint mobility, weakness, a lack of range of motion, those type of things are what all the different type of therapies are going to promote. So if we can get the treatment to address the underlying causes, then we're going to get rid of the headaches. Um, I would say how someone holds tension in their body is going to very much relate to the headaches that they're having. So if your posture is forward head, you're working aggressively in that position to get projects done or to because of a productivity demand at work, we need to change around the underlying tension of the position you're holding. We can do that by getting more regular movement throughout the day. But ultimately, when it comes to cervicogenic headaches, we've got to be thinking about the upper cervical spine, the C0, C1, and C1, C2 joints. We need to be thinking about thoracic mobility in the CT junction. We need to be thinking about scapular strength and mobility, neck range of motion. All of those things are going to be key in helping treat someone with cervicogenic headaches. So I hope you enjoyed this video on all things cervicogenic pain. If you have questions, put them in the questions box. If you like the video, please share it with a friend and subscribe. Um, we will keep coming at you with more videos, more videos of the similar format on how to learn how to the kind of all cause of what is the underlying issue behind many of these conditions.